Okay, I would like to welcome to the stage Joan Henneberry. Joan has lived in Colorado since 1980, and she's spent most of her career in our Colorado state government doing sort of all sorts of jobs. She's passionate about maternal and child care and health care, and I think that's what she's going to speak about today. So welcome, Joan.
Thank you very much. Thank you for having me, and thank you very much, Jane and Larry, for inviting me to be part of the symposium this year. This is my first time. When I came here yesterday, I would never in a million years have used the word scientist as to describe me, but I am going to now because of your generous definition of being a scientist. And I did wear my chemistry top in case you didn't notice that. So I'm going to start. What I really want to talk to you about today, I'm going to start with a shameless advertising of our firm. I work for a national healthcare consulting firm called Health Management Associates. We have 22 offices around the country, about 200 colleagues. And the work we do is really about helping public sector health insurance programs perform better for the consumer and perform better for the payer, which is, in our case, almost always government. And we do that through policy works, delivery system work. We have clinicians, we have analysts, but again, in the end, we feel very strongly, and what we're really all about is helping people get healthier. We don't do much work in the commercial world at all. It's all really about Medicaid, Medicare, and other government-funded programs. What I really want you to leave with, though, after I talk, I'm going to show you just a few slides with some data points and statistics, but the real message I want to leave you with is what Medicaid is all about. And in the end, yes, there's, a room full of regulations, state and federal rules and regulations, and all kinds of hoops you have to jump through to run a Medicaid program in a state. But in the end, it's really only about two things. It's about people and providers. And you have to have both of those things, and they have to work in unison to have a successful Medicaid program. And I'm going to describe certain aspects of Medicaid to you, but I want you to constantly be thinking, put an image in your head of what that looks like in the human beings that are served by Medicaid, because that's really what it's about. It's about the human beings that get benefits from the program. Okay, so just a few data points. I want to give you a quick little history. So Medicaid started in the same year as Medicare in 1965. They were both passed into law. Most states started their Medicaid program within a couple of years. Medicaid is an optional program for states. A state does not have to have a Medicaid program to serve low-income families and kids. But every state does. And in the early days, in the first 20 to 30 years of the Medicaid program, it was directly linked to welfare. So you got Medicaid benefits in our country or in your state if you were also eligible for welfare at the time. And welfare at that time had a very low bar. So Medicaid was designed to be the companion health care service to go with people who were all so poor they were also getting cash assistance. Now, just to give you a reference point, I should have looked up what poverty was in 1965, so I apologize. Today, for a family of three making $20,000 a year, that means you are living in poverty. A family of three making $40,000 a year puts you at 200% of the federal poverty level, so you're still eligible for some benefits. So imagine trying to live on that amount of money, and imagine how hard it would be to purchase health care or pay for your health care bills. Now, the other thing about Medicaid, when it first started, when it was directly linked to welfare, it really was only about paying claims. All the states really did was take their federal money and match it with the state money, and then people would go to the doctor and we would just pay the claims. The claims would come into the state agency or their IT vendor, and you'd make sure that the person was really eligible, and you'd make sure the claim was legitimate, and you just paid the claims. That's really all it was about. Very different today, and you're going to hear about what has happened. So there was a very important event in 1996. We passed national welfare reform. States had been doing a lot of experimenting in those first 30 years of Medicaid and a lot of experimenting with their welfare programs. And in 1996, Congress passed welfare reform and delinked Medicaid from welfare. Now, if you remember what was happening in the mid-90s, this will make sense to you. The failure of the Clinton health plan. Remember, the Clintons wanted a national health reform program, an approach that took care of everyone in the country. That failed, so they wanted to give the states a lot of flexibility to leverage their Medicaid programs and expand those programs to cover more people and to turn those programs into more comprehensive health care programs, which they could not do through the Clinton plan. So that was one of the reasons why the president really supported the delinking of Medicaid and welfare, so that we could turn Medicaid as much as possible into a broader scope program serving more people. And that is really important because it set the stage then for 2009 when we passed the Affordable Care Act. In all of those years, though, in the 90s and into the 2000s, states were really, we jokingly call them the laboratories of invention and innovation. It was really the states that were experimenting about how to take better care of the Medicaid population. States were expanding eligibility in voluntary ways. They were adding more services. They were using what we call waiver authority to be able to do things that ordinarily you can't do in a Medicaid program, to serve populations. When you have a crisis like we had in the mid-'80s with HIV/AIDS, states were able to get federal waivers to add services and serve people living with HIV/AIDS that would otherwise not be eligible for Medicaid. So there was a lot of innovation going on in states in the 90s and early 2000s prior to the Affordable Care Act. But what the Affordable Care Act, you might not remember this part of it either, in the original bill that was passed and signed into law, Medicaid was a mandatory expansion of Medicaid for the whole country. Every state was going to have to expand Medicaid up to 138% of the federal poverty level and serve everyone. One of the most interesting populations that was going to get services that had pretty much never been served by Medicaid before were men. Medicaid historically had been for pregnant women, kids, people living with disabilities, tied again back to welfare, lots of single moms and kids, but unless a man was living with a disability and became eligible through that disability pathway, men weren't served in Medicaid. We didn't know very much about their health care needs and how to take care of them at all. We had decades of experience with pregnant women, decades of experience with kids, very little experience with men. But that part of the Affordable Care Act, what it really did is we decided as a country, this was one of the biggest social policy changes in our country since 1965. We said as a country, we are going to use Medicaid as the platform to provide health insurance for everyone in the country who is income eligible up to 138% of poverty. Now, unfortunately, the Supreme Court decided that the federal government could not make states do that because the states do have to put up a share of the funds. Now, good news is 39 states chose to go ahead and expand their Medicaid programs. Unfortunately, some of the biggest and poorest states in this country did not choose to do that. So you've got Texas and Florida, anchors, almost all of the Southeast, the poorest states in the country, with the exception of Louisiana, have not expanded their Medicaid programs. So you still have a lot of uninsured, low-income people living in poverty in those states without health insurance. So here's the program today. We have 74 million members. Medicaid has become the largest health insurance program in the country in terms of enrollees. 1 in 3. So here's where I want you to start thinking about who the people are, who are the real people, and put faces to these numbers. 1 in 3 children in this country gets their health care through Medicaid. 50% of the births in this country are paid for by Medicaid. People get their prenatal labor and delivery paid for through the Medicaid program. And mom gets 60 days postpartum, baby gets covered for a year automatically. If your baby born on Medicaid, your mom was on Medicaid, you stay in Medicaid for a year, at least a year, and most would stay beyond that. Here's a number that most of you probably don't know, especially if your history is that you knew about Medicaid as a linkage to welfare. What you don't know is 1 in 7 elderly people in the United States get benefits from Medicaid in addition to Medicare. They are those 11 million, what we call dually eligible individuals. They're in Medicare, the other entitlement program. Everybody 65 and over goes into Medicare. That becomes your national health insurance. I'm eligible this year. Your national health insurance program for the elderly and disabled. But if you are also poor, which many elderly people are, you are then, in addition, eligible for Medicaid to wrap around and provide services that Medicare does not pay for. So they are companion programs for the elderly and some disabled populations, including the 10 million people in this country who live with disabilities every day, and some of whom work and have access to health care coverage through their employer or other health care services, but those services are not robust enough for the things that they need to really take care of their disability. So Medicaid also can wrap around as a secondary payer for people with disabilities. So $565 billion, it's a state and federal partnership. Unlike Medicare, that is totally run by the federal government, we pay for it in our Medicare taxes that are taken out of our paychecks, along with other tax dollars. Medicaid is a state-federal partnership. Shared expenses are paid for by the states putting up some of the money. It's generally 50-50. It's too complicated to explain. There's all kinds of categories, but it is a shared program. So here's this next bullet is really where I believe we are today politically in watching this pendulum swing back and forth. For the first 30 years, we were linked to welfare. People saw Medicaid as a welfare program. Those of us who've spent our lives trying to turn Medicaid into a health insurance program and see it that way and see it as a valuable part of the healthcare infrastructure fabric in the United States, that's where we got with the Affordable Care Act. We are now coming back to the welfare lingo. And this particular administration, you'll see a map later on with what states are doing. You're going to hear these words a lot called, we want people to take personal responsibility, not the kind of personal responsibility we've been talking about here, how to actually give people tools to make them healthier. This is code for some of us are worthy of getting public assistance and some of us are not worthy of getting public assistance. So that's what you're going to hear me talk about a little bit. And it's not Medicare. It's always very surprising to me when I meet this is usually if somebody's running for office or a newly elected official and they have no idea what the difference between Medicare and Medicaid are. And they're quite different, as you see. Okay, so quick picture of Colorado so you know what's happening in our own state. I know not all of you are from here, so I apologize. We have 1.4 million Medicaid clients here in Colorado, enrollees, and 100,000 of them are those dually eligible Medicare, but so poor or so sick, they also get Medicaid. We spend $6 billion a year on Medicaid, and the expansion, actually, when Don Elliman and I were working for Bill Ritter, it was in Bill Ritter's administration that we actually expanded Medicaid prior to the Affordable Care Act. So we did expand to higher levels for pregnant women and for kids and for parents of those children. It was the first time in the history of Medicaid in Colorado that we had expanded beyond federal mandates. So after the Affordable Care Act, Governor Hickenlooper supported the bill that expanded Medicaid in Colorado in 2014. So you can see the impact that had on our rate of uninsured. We are covering more people, they're getting services, their bills are being paid, they're getting care coordination, and we hope that they will come out of the Medicaid door healthier than when they came in. But back to that previous comment I made about the dually eligibles, 34% of what we spend here in Colorado in the Medicaid program is for people who are also in Medicare. And that's because Medicare doesn't pay for everything that elderly and disabled people need. So when people say to me, well, we have to reform the Medicaid program, that is usually also code for we want to spend less money in Medicaid. You cannot reform the Medicaid program without reforming the Medicare program, because one of the biggest things we spend money on in Medicaid, state federal share, so this impacts the state budget, is on services that people in Medicare need and don't get. The primary one, nursing homes. Medicare does not pay for institutional care in nursing homes. Medicaid does. So when people need that care, they don't have the money out of their own pocket, they have not bought long-term care insurance, and they have to become Medicaid eligible as well. That's one of the most important things I hope you remember. So the emphasis right now in Colorado has been, they've done a very good job actually to organize their Medicaid program, to manage people better. They've adopted the principles of the triple aim, now the quadruple aim, reduce the cost, improve the client experience, improve the quality and the outcomes, hold providers accountable, but also improve the experience of the provider so that they stay engaged and stay at the table and serve people. There's a lot of exciting things going on here with payment reform that I'm going to talk about at the very end, but a lot of work to do. Certainly it's not perfect, but a good program here in Colorado. So just a quick slide to show you, once again, to emphasize how hard it is to reform or transform a large institutional program like this, and what some of the demographic changes are that are going on in our society that make it pretty difficult. As I said before, you can't reform Medicaid without reforming Medicare. You could run the best, most efficient Medicaid program in the world, but you can't do anything about the fact that every single day we have 10,000 people turning age 65 over the next 20 years, and that 24% of those folks are going to be living in poverty. So those are the 24% of the Medicare eligibles who are also going to need Medicaid. And that's what's driving the cost. 5% of the population that we serve in Medicaid drives 50% of the spend because they are sick. And they're really sick, and they're complicated. And I'm going to show you a chart about that. So just a couple of quick graphs. This is from the Kaiser Family Foundation. I'm sorry the data is a little bit old on this, 2014, but it really hasn't changed much. The percentages. So look at what you see here. 43% of the population in Medicaid are children, generally very healthy, very inexpensive to serve, really easy to serve, and they only account for 19% of the spend. Adults, 34% of the population, now that we've expanded, 19% of the spend. Most adults are pretty healthy too. If they've been chronically uninsured or underinsured before they come into the Medicaid program, once you get them caught up and stabilized and into services, they do pretty well. But then look at 9%, only 9% of the population are elderly, but they drive 21% of the spend. Only 14% are disabled, and they drive 40% of the spend because they're complicated and they're sick. This is, I'm not going to go through all these numbers, and this is actually from a colleague and friend, a guy named Tom Betlak, who runs the Medicaid program in Arizona. And he put this together based on some GAO, Government Accounting Office data, I believe. But this just shows you the complexity, what a medically complex Medicaid member looks like. So people don't come in just with asthma. They have asthma, and they have HIV, and they have a mental health diagnosis, and they have a substance use disorder diagnosis, and they need long-term care support services. So this is why they're complicated and expensive. I'm sorry, Larry, what? Those are percent. So the people who come in with asthma, 24% also have diabetes. So if you look at the last column, people with asthma, only 17% only have asthma. Yeah, this is just to illustrate to you, and it doesn't add up to 100 because these aren't based on like unduplicated count. These are claims data. Yeah, thank you for asking that. So this map, I'm going to switch gears a little bit and tell you what I think we mean and what's happening as this pendulum is turning back to personal responsibility for healthy adults. That percentage that I showed you, what was that? The 34% that technically are healthy adults, or what some people refer to as able-bodied adults. Now, first of all, in Colorado, about 70% of these folks do work. They have a job. They just work in low-wage organizations, or they work for small employers that don't provide health insurance, or their employer, maybe they get coverage, or one adult in the family might get coverage, the worker might get coverage, but the premiums to add their families are just way too expensive. So to think that every single adult in Medicaid is not working is totally, totally wrong. 70% of the adults who can work do work. So yes, we could do a little bit more to help the people who don't have jobs get those jobs. But generally speaking, the reason they don't have a job is because they're undereducated. They are not qualified to do the jobs. I don't know if you all saw a story about a week ago that right now in time we have exactly the number of unemployed people in the country as we have job openings, but they're not in the right place. They don't have the right training for the jobs that we have. So what these personal responsibility initiatives are really about, they're coming from a fairly conservative standpoint. Now, don't misunderstand me. Some of the best Medicaid programs in the country and initiatives have been started by Republican states and Republican governors. That good ideas can come from everywhere. But there is a groundswell of interest right now, particularly in red states and among Republican governors, to reattach Medicaid to welfare. And if you listen to the director of the Centers for Medicare and Medicaid speak, her name is Seema Verma, and I'm not saying this in a critical way. I want you to really understand their philosophical feeling about social health care programs. They truly believe that if we give people too much support, that will enable them and they will not be able to pull themselves out of poverty, that it will make their lives worse, that they'll become dependent on those programs. They really, truly believe this. And that belief is driving many of the decisions that they're making and the policy choices that they're making, and it's what's driving some of the decisions that states are making as well. So in this current political climate, state-level healthcare reforms are taking on this more conservative market-based approach, which is very different than where we were headed 3 years ago with expanding our Medicaid programs and using them as the foundation for national health insurance. So they also believe, it's a very common belief among some legislators and governors for sure, that Medicaid is not just a health care program, it is part of that welfare cadre of programs. That Medicaid is broken with poor performance relative to private insurance like access and outcomes. The data do not support that at all. Every survey done, the HEDIS measures, which are the quality measures that health plans use, standard set of quality measures that health plans use and different provider organizations use, CAHPS, which is a consumer satisfaction survey. Medicaid performs just as well as private insurance programs. And that they also, this is also about shrinking government. There's just a fundamental difference frankly, between the two major political parties about what role government should play in providing health care and health insurance and where it should step away and leave it up to the marketplace. So there are some very fundamental philosophical differences that you have to keep in mind as you're watching this policy play out and as you're thinking about your own position on the policy. This is just another map to show you the kinds of things that states are doing and what's coming under this umbrella of personal responsibility. And what it is it's reattaching administrative requirements and barriers that will make it harder for people to access Medicaid services than they were able to even 2 years ago. So states are using what we call this waiver authority. You go to the federal government and you say, we would like a waiver and not have to do things this way. We want to do it this way instead. Now, one thing to really remember about waivers, states have had access to waivers since the beginning of time. In Colorado, we probably have at any given moment 15 or 20 active waivers of in the Medicaid program. But historically, states have always used waivers to add things to Medicaid, to serve more people, to add benefits that weren't mandatory benefits, to try new things that they're supposed to be innovations, to see if we can do this a better way. Can we manage the population and get better outcomes? That's what states have historically used waiver authority for. These waivers are to take things away. That's the current political environment. States using waiver authority to serve fewer people, to cut benefits, to cut eligibility, to add more burdens to the lives of these families of 3 trying to live on $20,000 or $30,000 a year. So things like work requirements, saying if you're going to get Medicaid benefits, you have to show us that you're going to be working at least 20 hours a week. You either have to be in school or you have to work or be engaged in some sort of community service. This is a very common one. About a dozen states have waiver requests in to add these, and several have been approved already and are implementing these policies. Increased cost sharing. Medicaid already has some cost sharing for some populations. It's very nominal. So quite a few states want to increase the financial contributions that their members have to make. Member accounts are like health savings accounts where you put some money in, the state will put some money in, you can use that money for health clubs or other things that are not a benefit. Those are very popular. Limiting benefits and cutting back on eligibility so that you have to be even more poor than you are now to get Medicaid. And then premium assistance. Premium assistance has actually been around for a long time. It's a way to, if I have a job and I have access to my employer's insurance, but it's just too expensive, I can't afford it, you can actually take your Medicaid dollar with you, if you will, and pay that premium and keep you in that commercial plan. It's a little cumbersome to administer, but the policy is not a bad policy at all. Finally, I just want to close and give you some sense of some of the innovations and the things that if you are in a good state where you have support for your Medicaid program and it's not under attack, it's really a great time to use the Medicaid dollar and leverage. Look at all those covered lives. 1.4 million covered lives in Colorado. You add those to the state employees and the retirees. You add those to everybody living in an institution or a correctional facility. You add those to any other public dollar that is being spent, then you've got a lot of buying power and a lot of influence and a lot of leverage that you can use in the marketplace to drive innovation, cost reductions, and improve quality in the overall healthcare system. And that's what a lot of states have been trying to do. There are pioneer states that have been working on health reform for 30 years. Minnesota, Massachusetts, Oregon, Tennessee, Arizona. Who would think that state? They're doing some very innovative, cool stuff down there. So states are also, right now, using their Medicaid policy levers and funding to address some current critical problems like the opioid crisis. And I don't need to tell you, we know what a disaster that is right now. So you can use a waiver, a Medicaid waiver, to do a good thing and cover people who are addicted to opioids and build programs to serve that population that you would otherwise not be able to do in the Medicaid program. You could use a waiver to address the opioid crisis, to design new and more effective substance use disorder treatments and opioid inpatient treatment programs, and a number of states are doing that. It's a very exciting, and this administration is approving those waivers. They're very supportive of that. You can use the Medicaid program and that leverage and all of that money to move to value-based purchasing and alternative payment models in the healthcare system. So in the 90s, most states decided to manage their Medicaid programs through partnerships with commercial health plans or Medicaid only or local regional health plans. We did this in Colorado as well. And what you did, it really wasn't about managing the population, it was managing the budget. You had your whole Medicaid population, you put out an RFP, a request for proposals, or you just picked some health plans, you gave them a per member per month monthly capitation, say, here, go for it, you take the risk, you take care of everybody, and then you could wash your hands and say, see, Joint Budget Committee, we're managing our budget better. Nobody really cared about quality. It was all about managing the budget. That has really, really changed. States are holding their health plan partners accountable for the triple aim, for better outcomes. They have key performance indicators, and they've also said to the health plans, or in Colorado's case, we use something called regional accountable entities. We're saying you are responsible for the health of this population. We're going to give you a certain number of people to take care of. We're going to give you money to do that, and you are responsible for the outcomes. Now, what states have also started to do in the beginning, when they had these relationships with health plans, they realized, okay, so the health plan is taking the risk, they're getting this capitated monthly payment to do that, but then the health plan was turning around and just paying all the providers still transactional fee for service, which only gives the providers the incentive to just keep doing more whether you need it or not. You heard Dr. Weinberg yesterday about, part of the reason we can't reduce the costs is we keep paying for things that people don't need, that we know don't work, that have no value, but it's really hard to take those things away from people. So the new payment models and what states are doing, we're doing this in Colorado as well, many states around the country, is we're looking for different ways to pay providers, different ways to incentivize providers to help people get healthy and to only use the services that we know will make a difference for them and to stop paying for things that won't make a difference. But you have to reward the providers to do that. I have never met a physician or a nurse or a lab tech or anybody who is not willing to be held accountable. They just don't want to be held accountable for things they have no control over. And they want to be rewarded for when they do good, when they keep people healthy. We don't reward them for that. You saw the other chart yesterday where we're really a system of sick care, not well care. So we have to start rewarding our providers differently. Lots of exciting work going on there. We have to address the social determinants of health. You can be in the best system in our own on Anschutz campus, in Geisinger, in Intermountain, in Cleveland Clinic, you name it. You can be in the best exam room in the world with the best providers, the best labs, the best diagnostics, and then you leave that room and you go and sleep along Cherry Creek in Denver, or Boulder Creek here, or in your car, or in some ratty hotel on Colfax in Denver, and there's only so much that healthcare system can do to make you healthy and keep you healthy if we're not addressing everything else that's broken in your life. And so healthcare systems and delivery systems and payers are taking on more of these responsibilities because they know it's better to take care of those things up front than to be paying for 3 or 10 emergency department claims every single week by a homeless man who has serious and persistent mental illness and no good place to live. He's going to that emergency department every single day, every single week, because that's the only place he has to go and the only people who will take care of him. So it's better to address those other things and invest our money in that. So lots of exciting things going on there. Reducing the total cost of care, I talked about a little bit. A big emphasis right now in pharmaceuticals. In Colorado, they only amount to about 5% of the total spend, so they're not huge in terms of the percentage, but that number is going up a lot. And as we see really important breakthrough drugs, important drugs for the Medicaid population, things like for hepatitis C and for cystic fibrosis, these are very expensive. And it puts a lot of pressure on those Medicaid budgets, so they're paying a lot of attention. Massachusetts has a waiver into the federal government to create a closed formulary, so treating the Medicaid clients very much like we all are in commercial plans. This is on the list, this is not on the list. That is not allowed right now in Medicaid, so it'll be very interesting to see whether they get approval to do that, to limit the actual brands and types of drugs that go on their formulary. Because if one state gets a waiver like that, I can guarantee you many others will go after it. And finally, integration of care, including long-term support services and behavioral health and primary care. It's a huge initiative right now in Colorado. Again, it's very hard for the physical healthcare providers to fix what's broken with us if we have chronic untreated mental illness or we have chronic untreated substance use disorder, and you're trying to treat my diabetes and you don't even know that I'm an alcoholic, let alone that I'm not getting any treatment. So really important in Colorado. A lot of great work going on in partnership with the university. But all of these initiatives that are funding, all of the initiatives that have been funded, like integrating primary care and behavioral health, changing practices, looking for new payment models, these are all really exciting and they're yielding some interesting results, but they've almost all been primarily funded by money from the Affordable Care Act. And most of that's going to be drying up within the next couple of years. So at the state level, there will be great pressure to think about how we sustain some of this work and how we continue the work and improve the healthcare system. And this is going on in every single state because most of that money is going to be drying up. And I really do not see new sources of funds for innovation and continuing this kind of work coming out of the current Congress or current administration. I just don't think it's going to happen. So people are going to have to continue to do what they're doing with less money. It really means the work that you've all been doing. It's so important to help policymakers and the executive branch who's implementing these policies have the evidence and make evidence-based, data-driven decisions so that they can do the right thing and help accomplish some of their goals with the ongoing challenge of limited resources. So thank you very much again for having me here, and I'll be happy to answer any questions.
Yeah, perfect. He's coming up to you in the red shirt. Yeah.
I was a AmeriCorps volunteer a couple of years ago at St. Anthony's North, and I would talk to patients in the hospital, and they had negative, if a patient came back within X number of days after their hospitalization, they got fined. Is this still part of the Medicaid process, or where is that in the policies?
So, I think probably about 7 or 8 years ago, one of the incentives that was put into the Medicare program was not paying for readmissions if people came back to the hospital within 30 days. Thank you. If you were discharged and then you showed back up in the hospital within 30 days because of that diagnosis and that experience, then you weren't going to get paid for that. And Medicaid in Colorado, not every state has adopted that policy, but Medicaid in Colorado did as well. It's a proxy it's based on an assumption that we didn't do very good discharge planning and that we didn't make sure that that patient was going to a supported, safe place, that they understood what medications they needed to take, that they had a home visit shortly after, that they were connected with a primary care doc. And if they don't have all of those things and they go home, and then they get sick again, or they have a complication and there's nobody there to help them and they don't know where to go, they come back into the hospital. So it was a policy designed to incentivize hospitals to do better discharge planning and better connections back into the community. Yeah.
While you're up there, why don't we grab the guy back there?
So there was a ballot initiative in 2016, I think it was called Colorado Care, Universal Health Care in the state. I was just wondering if you thought the ads rating, if that was a good plan, a lousy plan, and if so, how it would be better.
So you're talking about the initiative that would have created, give the authority to start a plan toward moving toward a single payer system, right? Yeah. So I don't remember the details of the plan or why exactly it didn't pass. You know, when we use those words single payer, if everyone in this room might have a different definition of that. If you remember in the beginning of the Affordable Care Act, the state of Vermont made it very clear from day one after the ACA was passed that they wanted to move to a single payer system. And you know, what do they have, like 1 million people or something? When you take everybody in Vermont that is Medicare or Medicaid or a state employee or in an institution, you know, that's pretty much everybody. So it made sense for them to think about, well, let's just put all this money together and manage it together and set prices and do all that. Well, guess what happened? The insurance industry came in and there's no way they could ever pull it off. I don't see, I'm sorry to say, we have built a healthcare system that is so, and well, it's not really a system. We have built this thing. There are some systems, some very high-performing systems within this thing. Denver Health and Hospitals is a high-performing, Geisinger, Intermountain Health, Kaiser Permanente. I mean, there are a number of great examples of high-performing systems that are within this other monster that we've created. But there's so much of the healthcare industry that is for-profit and controlled by Wall Street. I don't know how you could take that, I don't know how, I'm not smart enough to figure out how you undo all that and not create even more chaos than we have already. I consider myself, I call myself a scapitalist, which is a social capitalist. We're a capitalist country. We you know, that's what we are. We were built on that, and we count on things to make money and profit because we need to. But I'm also dedicated to the social. You can be a capitalist and still care a lot about social problems and help build social fabrics. And that's why I'm so passionate about Medicaid. I believe in publicly financed programs. Can we do better on them? Sure. But we have to have them in order to preserve people. I just can't see us going there. And I have so much respect for the people who are still fighting that fight. And honestly, the more complicated and messy we make this, it just gives them better ammunition for why we need a single-payer system. I just don't see how we undo what we've done.
Joan,
Joan,
Larry,
is it okay? So could you go back one slide? If you, I want to ask something that's exactly aligned with what you just said. So if I understood the numbers, there are 1.5 million people in Colorado on Medicaid, and we spend 500.
6 billion.
Say it again.
1.4 million enrollees, we spend $6 billion.
So that's $5,000 a person.
Yep.
Or something like
About
that.
right, yeah.
And so now imagine that someone looking at this slide had a great idea to help make this work. And it was triple aim or quadruple aim centered. And the idea was going to cost something, $100 a person out of that 5,000. And you would save money and deliver better health care and people would get better educated, all that stuff. And it's wonderful that this system is probably organized differently than anything else because there are probably 5 people in the entire Medicaid Colorado thing that could make a decision to do that if there was money that they could squeeze out of that $5 or $6 billion. Is that the way it would work if someone had a good idea? And who would you go talk to? Say their name out loud, names.
So yes, that is possible. In fact, in the Affordable Care Act, there is a special waiver authority that was designed just for states to come to the federal government and say, look, we did everything you wanted us to do. We expanded Medicaid, we built a marketplace, we changed our insurance regulations, but we still think we have a better way to do it in our state than what you're forcing us to do with all your rules and regulations. Give us the money that you're spending anyway, and let us do it our way. So if you wanted to do that, if you had a better idea, you start with stakeholders, You have to start with consumers. You know, part of what's still wrong, in my opinion, in the way we deliver healthcare is it's still really designed primarily for the provider. We have to stop doing things to people and do things with people. So we start with building consensus. The ballot initiative was what that was really about. We've had 3 or 4 different cost containment commissions in Colorado. They come up with great ideas. Can we get the legislature to do any of them? No. So you build the momentum, you get legislative support, you talk to the governor, you get champions, you talk to the business community, because they don't like how much money they're spending either. They just have to spend it in order to get the best workforce. But they're not happy. You talk to any CEO, they're like, I hate that healthcare thing. I wish I didn't have to spend so much money on it. So you get the business community behind it and you build momentum. That's how it works.
Well, let's thank Joan. Thank you very much.